the clicker? Okay, forward and back, right? Okay, that's good. I hate these screens because they make me look really old, and I also see how little hair I have.
Why do they put these screens where we can see ourselves right in front of us? Oh my! Oh. Good morning, everyone, and welcome to our session this morning on cancer. I'm so aware of not being really mean when I ask people to come draw their attention forward. Everyone's so obliging. Thank you so much for making this easier. All right, today's session is on cancer in First Nations in British Columbia. Thank you all so much for being here. We know that you had lots of choices about where you could be today. And who doesn't want to do something about cancer? From my work on the board of the Canadian Partnership Against Cancer, a $100 million 10-year project by the federal government to bring together cancer partners so that they can improve their work. I know that from coast to coast, from community to community, non-Aboriginal people and Aboriginal people, we all know that there's more that could be done, and we all know that we are going to be affected by cancer, or we've been affected by cancer in our families, in our communities, amongst our loved ones, and maybe even ourselves as individuals, that perhaps amongst you there are a goodly number of survivors and people who've been on a very concerted cancer journey. So today we have a few experts, and we've been working on a presentation for you that we would like to go through so that we can throw open the floor. But one of the first things we'd like to do is to make sure that we're all in all on the same page, landing on the same page. For the First Nations Health Authority, we understand that we at the First Nations Health Authority, and I really shouldn't even say we because I work for the Ministry of Health, and I don't speak for the First Nations Health Authority, but we do work collaboratively. At the First Nations Health Authority, we're very clear that we need partnerships in cancer, that we as First Nations are not taking over and isolating ourselves in cancer services. We're not taking a section of the BC Cancer Agency and saying we as First Nations are going to deal with cancers by ourselves. That is not the situation. It's very clear in the case of cancer that we need our experts, and we need an expert agency, and we need our partners regionally and centrally. So with that in mind, we have a few speakers from a few different areas, and that's why we would like to present now from a few different perspectives, describing services just to refamiliarize you with the cancer journey for different kinds of persons with different kinds of cancers from different parts of the province. I forgot to say my name is Tlesla Evan Adams. I'm the Deputy Provincial Health Officer for Aboriginal Health, and I sit on the board of the Canadian Partnership Against Cancer. And my mother is a breast cancer survivor, and we walked that journey together, and partly with Nadine Caron a few years ago. And she's well, but it was definitely a very different experience to walk it personally than as a clinician. So with that, I'd like to invite Dr. Nadine Caron and Dr. Nick Foster to come and join us. Nadine Caron is known to many of you. Perhaps some of you heard her speak yesterday. She's a First Nation surgeon in Prince George and attached to the University of Northern British Columbia, and a dear friend, one of my inspirations to go into medicine. Nick Foster is a Kiwi and has been with the BC Cancer Agency for several months now, on loan from the BC Centre for Disease Control. He's the Chief Operating Officer, BC Cancer Agency. So if I can invite you both up. And hopefully you all have your little clickers, your voters, for the later part of the presentation. If you don't have one, if you could put your hands up and we'll bring you one.
Would you like to hear that? I'll bring it. So are you saying a few words, or am I starting?
I can start if you want, because I'll be really quick. Good morning. Thank you. Just to echo Evan's words, really, is to thank you so much for coming. Cancer is about 90 plus, more than 90% of the work that I do as a clinician, meaning patients that I see that come to me with the diagnosis of cancer, come to me with the concern that they may have cancer, or come to me with the possibility with things like a lump that they can feel in their breast, or other symptoms that they or their doctor or a family member has noticed that they want investigated to figure this out. And I have to say that I echo Evan's words as well in terms of the experience of going through this as a clinician. It can be heart-wrenching itself, but I can't imagine going through it personally. But I have walked that journey with loved ones and how terrifying it can be. The things that really fill that gap to make something scary slightly less scary, to make something that hurts slightly less painful, to make someone's journey improve, there are ways to do that. But the thing is that the answers don't lie with the cancer agency or with your physician or with the hospital administrators, and we know that. Because as First Nations people throughout British Columbia, there are gaps in our services, not just in something not being there, but something being right there, but just not fitting with us, not feeling right. Perhaps it's around the cultural competency that we discussed the other day. Perhaps it's the challenges that our communities have that are different. Perhaps it's where a lot of us live in terms of rural, remote, northern, whatever it is. What we're looking for today is to start figuring out that partnership with agencies like the BC Cancer Agency, with the PHSA, with our health authorities, with our hospitals, with our healthcare providers, and recognizing that we can improve these partnerships so that if we ever go through this journey, that it's going to be something that we have designed and worked together so that we know what we're doing. The other thing is, and I've talked to Joe a lot about this, is the other part of it is really shifting our focus, the wellness aspect of it. And I think this is one area that we can be leaders in First Nations where a lot of the focus when it comes to the Ministry of Health, sorry Evan, he is associated with the Ministry of Health, is the fact that they focus on the diagnosis and the treatment, which is exactly what they're supposed to do. But like we said yesterday, forgetting about the prevention and the screening, which can really change the number of people who have to go down this path and how they go down it. And so one of the things that we can do is work on that prevention, that wellness model that we know intuitively, so that not only is that healthcare system going to be there for us, it's going to be culturally competent and more in partnership with what we need and what we expect and what we deserve, but it's going to be a building down the street that hopefully less of us need and less of us need to utilize because of the prevention that we go through and because of the screening. And that's looking at the whole journey and the whole spectrum. And we're really looking forward today to get your input in terms of what your expectations are, what your desires are, what your concerns are. And please feel free to, whether it's in the small group breakout sessions at your table, or if it's question and answers, or it's comments you want to make when we're going through some of the questions that we ask up here, please feel free to have your voice heard. And if this is not the forum, there's also a table downstairs that you can go and talk to us about. And of course, there's also just individual communication that we can make available to you so that if there's something that you need to say, there's always a place where your voice will be heard. And that's the beautiful thing about what our approach is going to be and what the First Nations Health Authority is aiming to do. Thanks.
I hate these screens. I realise how little hair I have left. It's, normally I don't have to, see that part of me. My name's Nick Foster, as Evan introduced. I'd like to acknowledge the First Nations Health Authority. I think huge accomplishments, and I'm very proud to be standing here and privileged, I believe. And thank you. Thank you for inviting the BC Cancer Agency to be here today. I'd like to acknowledge Coast Salish for holding this event in their territory. And before I start, I'd like to introduce some key people from the Cancer Agency who are here today. They're among you. So we have Fiona Walks, if you could just stand up, Fiona. Fiona is our VP of Safety, Quality and Supportive Care. Marianne Taylor, somewhere here, is our VP of Systemic Therapy. We have Pam Tobin, who's our Regional Director of Operations for Centre of the North, and also has been a key figure for us in a lot of our Aboriginal work to date. Lisa Caron is our Senior Director of Screening for the province, for our agency. And Leslie Varley is here, of course, from PHSA. Right. Can we have the presentation, please? There we are. So it's customary where I'm from, and I believe it's true here too, that one introduces oneself a little bit. So I'm going to do that, even though Evan did that. So where I'm from, this is called a mihi mihi. And so I'm from Aotearoa, or New Zealand, and I have lived in various areas, and I've been very privileged to live and work in two areas in particular. One is Rotorua, and which also incorporated Taupo, and the other one is Tairāwhiti, which are both areas with a very high Maori population, at 35% plus. And as such, I worked there both as a clinician, and then later I actually came back to Rotorua as their Chief Operating Officer. So had really fantastic experience and involvement in the delivery of culturally appropriate care, because many of you know, I believe, how things are down there. Still work to do, of course, but there are some great initiatives. I then came to Canada. Don't you like that? I did that last night. That was fun. It's not to scale, by the way. And I've worked at those three places, as Evan talked about. And I just want to acknowledge Melanie Rivers is in the room from Squamish Nation, and I was very privileged to work with Melanie at the BC Centre for Disease Control. And she is now, as of day 3, with the First Nations Health Authority. Where's Melanie? Yep. So the challenge, and I know a lot of you know this, and in fact Nadine kind of did my talk yesterday, and did it much better than I can. So I'm going to be really quick, because I really, we're here to listen. So I'm going to be really quick. I want to talk about, very briefly, the incidence and prevalence of cancer. So the incidence is the number of new cases, and the prevalence is the number of cases existing, so it includes people living with cancer. It's increasing. It's increasing by 3% plus a year. That's a significant challenge for all of us. We heard these stats yesterday. 2 out of 5 Canadians are expected to develop cancer during their lifetime. 1 out of 4 Canadians is expected to die. So, the good news here is not everyone with cancer dies from it, right? The odds are getting better and better. And in fact, British Columbia leads Canada in its outcomes for cancer as a province. And we'll come back to that a bit. The patient journey, Nadine really went through this very well yesterday. And the BC Cancer Agency incorporates most components of this, all of them to some extent. So the one area where we're probably less involved, because it really spans into public health, is prevention. As we heard yesterday, healthy weight, not smoking, alcohol, exercise. They're great preventative measures for cancer. They're also great preventative measures for heart disease and other components. So they're really very much a public health measure. We have screening programs, and I'll talk about those shortly, just very briefly. But really, the Cancer Agency, it encompasses each component of this, with really an emphasis. The bulk of our activities are really around screening and treatment and follow-up survivorship and end of physical life care. The modalities of treatment, I'm sure most of you know this, is surgery, radiation therapy, and chemotherapy, which is the drug therapy. There are a lot of developments in drug therapy, particularly the move to more oral medications rather than intravenous medications. And secondly, the role of genetic testing. And genetic testing really is about, it's really personalizing medicine. So we know, for example, there are some medications that only certain people will respond to, and it's related to their genetic makeup. That's really important because, one, you can actually avoid giving someone a toxic drug which isn't going to do any good. And secondly, you can give treatments that are effective for that individual. And I think really in the next 10 years, it's already starting, but in the next 10 years, we're going to see a huge growth in the role of genetic testing. And that also will be combined, I think, with change in the way we administer treatment. And I think there's huge opportunity in that. And opportunity for First Nations in that too, because it changes how we deliver care. And related to that is, with the growth of incidence and prevalence and survivorship, so more and more people surviving cancer, so they're living longer, and some get second cancers. They get a different cancer. With that, we have to change the way we deliver our care. Because it's really not sustainable. Can't tell you exactly what that answer is yet. So I'm going to tell you about the BC Cancer Agency. We're an agency of the Provincial Health Services Authority, which is the authority you've never heard of, really. Mainly because it's not a regional health authority, unlike Vancouver Coastal or Northern Health or whatever. It has a province-wide mandate, and it's actually a society. So it's actually like the First Nations Health Authority. It's not really an authority at all, I guess. But it's made up of these societies, and of course cancer's top of the list because I put the slide together. But you'll recognise a number of these. Our mandate is really to deliver population-based control programs, and the beauty of this is the concept is it doesn't matter where you are in the province, you should receive the same standard of care and the same protocol of care. And for the most part, I think we do our best to make that happen. And I think that really relates to the outcome. So if Max Coppice, the president, my boss, all of our bosses here, if he was here, he would point out how in America there may be a really fantastic cancer hospital, but you can be 2 hours down the road and go to another hospital and it won't be so good. Whereas in BC, it's consistent, and there's strength in that. Aren't you pleased I'm not going to read every word? So we have 6 sites, and physical sites in the sense of buildings, and I never like concentrating on buildings too much, but these are important because this is where radiotherapy is delivered. Radiotherapy requires special buildings, and that's what those have, and you'll see that there's basically one in every health authority, 2 in Fraser. And then we have a number of other sites, and I'll let you look at this for a moment. We have, I think it's 38 screening mammography centres. We have a number of regional chemotherapy clinics. And we have networks. We have community oncology networks, and we really use a network system to help deliver care closer to home. So screening, we operate screening, cervical mammography, colon screening's just started. Hereditary cancer program is really a counselling and genetic testing service for people who meet the criteria or are at risk. Cervical screening, colon, mammography, I'm jumping around. Mammography program, we have, I think it's 38 fixed sites, Lisa, that's right, and 3 mobile vans. And there's been, I think, actually a lot of good work with screening in terms of improving access to First Nations communities, particularly with the use of the mobile vans, I think, in the more remote. Prevention, we heard yesterday, we have a very small prevention program, as I mentioned earlier. We work closely with the public health community and really focusing on awareness and education. And population health is really about surveillance and outcome evaluation. I've just got 3 more slides, and I just want to talk very briefly about our Aboriginal health initiatives, our more recent initiatives. And the first is the contributing to the Aboriginal cancer care strategy in the north. And many of you will be familiar with this, but I did want to highlight that the Canadian Partnership Against Cancer, CPAC, are funding at this point the development of a proposal which First Nations Health Authority is, I think, leading with us in support, along with our Métis and Inuit partners, to develop a cancer control strategy for the province. And I think that, I've got that right, Lisa, right? Pam? Yes. So, Lisa's going, what? That's going to be really, really interesting, and I really hope it gets supported by CPAC, and I'm fingers crossed, I think it will. Screening mammography, Lisa and her team have done a lot of work about improving take-up rates and participation rates and culturally appropriate materials and so forth. The outcomes unit, which is the population health unit, are currently working with the First Nations Health Authority to link our cancer registry, which records patients with cancer and their outcomes, with the First Nation client file. So that's something that First Nations Health Authority are leading, because we appreciate it's your data in that sense, but that will really help us. The last time anything like this was done was about 12 years ago, and the numbers were so small it was really hard to draw any real conclusions. And information is power. It's really important. We need to know. We need to know how we're doing if we're going to get better. And prevention programs I've mentioned. I should acknowledge that those photos came from a photo competition of youth in the Centre for the North when they were doing their cancer control strategy. I think they're just absolutely stunning. In conclusion, the Cancer Agency wants to become a more culturally appropriate and supportive organisation. We're committed to doing that. We've got a new president, we've got a new chief operating officer, we've got we're starting our strategic planning. This is just perfect timing for Joe to reach out to us. We're committed to bringing the successes of cancer care to First Nations communities. As I said, I think we do well on a provincial basis, but there are always, we need to do, there'll be areas where you need to do better. And we really value the partnership that's developing with the First Nations Health Authority. And finally, we're here to listen. A number of us are here from the senior team, and you've heard enough of me talking, and now I'm really interested to hear you guys talking. Thank you.
Thank you. Thank you, Dr. Foster. Let's call you Nick, if that's okay. And thank you, Dr. Caron, and we'll call you Nadine, right? Because I think it's very important for doctors to be approachable, and for us to be a little less formal So if we've all agreed, then that's great. So Nick and Nadine, thank you for that. And I would like to leave you some room to ask any questions at this point. We could probably take a few questions, just keeping in mind that our main objective today is for you to discuss some questions and leave us all with some ideas on how we might improve cancer care or add to the cancer care continuum of services, or how we might be of help directly to First Nations clients and communities. Yes.
So the question was, how are we going to make our programs more culturally appropriate? Well, I think probably in two main ways, at least off the top of my head. The first one is there's a cultural competency program that PHSA has developed, and we need to, the uptake at the Cancer Agency has been poor, in my view. It's been low. So that's something we are going to be pushing and building. I think the second thing would be the cancer control strategy that, fingers crossed, goes forward. The CPAC cancer control strategy, I think, will be very informative. And the third thing is we need feedback. We need to hear. We need to listen. And that's probably the most important thing, to be honest. And I think the process starts today, in a sense. And I think that's, these group discussions are going to be very important.
And if I could add, that is question number 3. We have 3 questions to discuss today, and that's actually the third one. So, so we'll be asking it back to you.
It's going to be a short test at the end, right?
All right. Yes, please.
Yes, Cooksjam. Chief Fred Sampson, Siska Indian Band. One of my questions was exactly on the same line in regards to traditional foods and how they would fit within cancer treatment. Also, you mentioned that preventive was actually a small part of the programs that you deliver. Well, I believe that needs to be quite a bit larger. And thirdly, is in regards to the genetic information that you're talking about, realizing that the position of the federal government is to talk about quantum blood. And there was a real fear around the collection of genetic information. So I would just be curious as to how you would protect that to make me feel comfortable in giving up my genetic information.
Okay, 3 things. What was it? 3 things: diet, genetic testing. What was the middle one?
Yes, traditional foods and how they fit.
Well, traditional foods, but there were 3 things: traditional foods, the genetic testing. Prevention, thanks, yes. So traditional foods, I'm not sure what you're getting at, other than I believe, if there's I recognize the importance of traditional foods and the cultural component that provides. I also realize that there's a history of significant benefit. I believe it's the yew tree that was, I think, in Haida Gwaii, that was used traditionally many years ago. So I acknowledge that. I'm not quite sure where you're going with the question, other than I believe if there are barriers that we need to address to enable access to culturally appropriate foods or healers or those components that are consistent with the cancer mission, then we need to look at those.
I was just thinking about how do you take it to the next level. Right now, First Nations are considering opening Aboriginal pharmacies. Well, how do you integrate traditional medicines into the pharmacies? How do you integrate traditional medicines into cancer or cancer prevention? Because within our communities, we have traditional knowledge about the treatment of cancer using traditional medicine.
Right.
But they are not recognized. This is our authority. So how do we bring that to a place of reality for our people in use of Malami traditional medicine?
So the question is, how do you bring traditional medicines into the fold, so to speak, of cancer care? I'm going to ask Marianne because I don't have the answer to that yet.
I suggest that.
Sorry.
So, I mean, I think the concern that the oncologist will have is, will they interact with chemotherapy? And if they don't, I personally, and I think most of us, don't have any problems with combining things. But if there's knowledge that they'll interact with chemotherapy in a negative way, then we're not going to be in favor of it because, you know, we feel strongly about the therapies that we offer. And then I think it's a compromise. If you want to do the traditional foods, then we forego some of the chemotherapy. And I think it's a decision that the physician and the patient make together, right? And we don't tell. When I practice, and I still practice, I don't tell people what to do, I advise, and I listen to what they're telling me, and then we come to a decision together about what we're going to do. So I think that's how I would approach that. Does that help?
And just around genetic testing, you know, the genetic testing we're talking about is effectively a lab test, and it's part of the medical record, like any other component, any other lab test that is done. Pardon me? Yeah, it's not shared without consent, and that's as kind of straightforward as that, or as complex as that, I guess.
Thank you, and thanks for the brief answers, because I didn't want to bog down in details so much as kind of open up the box of questions. And let's just have one last very quick question before, okay, we have someone there. Sorry, I thought we were taking a question there. We're taking a question there. Last question before we begin the rest of our session, which will involve your little voters.
Good morning. I'm just wondering about if the BC Cancer Agency is going to pick up on the, it was in the news that there is a tablet that is effective on treating rats and reducing the cancer tumors, killing the cancer cells. And there's something on there that said also that most likely will not be brought to the public because of how inexpensive the product was. I can't remember the name of that. Something like symbol DCA or something like that.
Okay. Well, I'll just speak generically about drugs. So, for drugs to be used in British Columbia, they have to be licensed in Canada, and there's a whole Health Canada process for that to ensure safety and regulation and all those components. Once that happens, there's a prioritization process that occurs, and that is quite a complex process because we look at the burden of disease, i.e. how many people have the condition, we look at the benefit that the drug provides, we look at the cost of that benefit, so to speak, and then we have to evaluate that across all the other drugs as well. So, sorry, I can't talk to the specifics of that drug because I don't know. Do you know that one, Marianne? Do you want to mention? Is there a microphone for Marianne?
And it has a lot of side effects, in particular peripheral neuropathy. So it has a lot of side effects, and so far not a lot of convincing activity, but it's still under study. So it's not something we're going to adopt at the moment.
Thank you very much. And we will leave more time for questions at the end of each session, because we have 3 questions that we would like to address to you. But before we get to that, I would like to remind you that we will be handing out a survey towards the end of our session together. This survey is very important to us. In fact, so important to us, we're offering a prize or prizes for the completion of it, which includes winning an iPad. So we hope that you're interested in having a new iPad and you're interested in our survey on cancer services and First Nations. Great. So the next part of our session will be 3 questions. We will give you several minutes to discuss each question, actually about between 12 and 14 minutes, depending how our timing is going. You'll be staying at your tables for this discussion. There should be a recorder at your table. Is that correct? People can write down their answers on a central piece of paper to the 3 questions, and I'm hoping that the 3 questions will be posted for you. If they're not posted on the PowerPoint in the front, we will ask you to write them down so you can discuss them. And before we start discussing, we're going to start each session with a quiz. So for the quiz, you will need your little voting devices. Sorry, I don't even know what these are called. I'll call them your little voting device. They're pretty self-evident in that there's a button for 1 or A, a button for 2 or B, a button for 3 or C. And here's the question. Cancer research shows that blank of cancers can be prevented through healthy lifestyle choices and policies that protect the public. And the answer, and A, 25%, B, 10%, C, 50%, D, 75%. So if you could enter your vote on your little voting device, your answers should start to show up on the screen as you're voting. We should be able to get a sense of which percentage of you think it's A or B or C or D. I hear the answers coming in. Dr. Caron's going to say a few words.
Okay. First of all, it looks like most of you have a good idea, and you have a great idea, 43% of you, because that's a general quote put out by the Canadian Cancer Society, is approximately 50%, or half of the cancers that are diagnosed in Canada in some way can be traced down to preventable causes. I love the optimism of 34%, and hopefully with time that will actually change as we start to absolutely eliminate the cancers that are more preventable, and then you have the ones A and B. It's important to recognize and to remember that there's many, many cancers that are not preventable. And that's particularly important when someone's going through the cancer journey, because the last thing you want on an individual, on a family, and even in a community is to think in some way that someone did something wrong. I think once a diagnosis is made, it's important to recognize that the next step is how do you take this journey and how do you fight this battle to get through it. Any questions about this statistic or about this question at all? Yeah.
I guess the data, is this directly related to Aboriginal populations, or is this population in general?
Oh, I'd really like to sit down and have coffee with you. You just asked a brilliant question. The answer is no, it's not specific to Aboriginal populations. And I think what you've done is just really hit the nail on the head in terms of a lot of the statistics you hear, a lot of the data, a lot of the information that you have when it's about cancer is not specific to Aboriginal populations. And in fact, that's one of a huge challenge when we're starting to understand where are we in cancer care, control, prevention, treatment, because that data and that understanding is really, really hard to get. So Nick already sort of referred to how the First Nations Health Authority is working with the BC Cancer Agency to share some of their data, but it's an ongoing challenge. And that's something that certainly, hopefully, the First Nations Health Authority in their research division is really going to address so that we can start answering those questions, what's preventable in our First Nations, Métis, Inuit populations. The goal is that we're going to be able to answer that with something specific to us, for us, so that we can derive our cancer care and prevention and wellness model for data that's really appropriate to us. So it includes all of Canadians. It's a start. Great question.
Thanks very much. So let's begin with our discussion topics or questions. Discussion topic number 1, how could we reduce the risk of our community members of getting cancer? How could we reduce the risk of our community members of getting cancer? And just to help you along, though I'm sure that many of you don't need help, You might talk about some programs that promote exercise. We've had the idea of food introduced. We've had the idea of traditional medicines brought forward, healthy eating, reducing drinking and smoking, physical activity programs, community kitchens, gardens, just some ideas that we've heard in the past, just to throw out there. But please discuss amongst yourselves and remember to record them on your papers in the middle of the table. We will be collecting those. In fact, it would be nice if we could display them. I'm not sure if we can on these walls, but if we could share some of these ideas with each other at the end, that would be great. So please discuss amongst yourselves.
that was the easiest, because that was actually my replacement bike.
How much time are we given? Okay.
I was just so moved by your story.
Oh, yeah. How do I scroll down on the BlackBerry? I used to have a BlackBerry. I used to have a BlackBerry. Oh, you don't.
Uh, 3 minutes. You have 3 minutes.
It would take the easy option. Quite funny, isn't it?
He was certainly not that age. I was like, okay, next time remind me.
You don't give kids an option you don't want them to take. Yep.
All right, so if we could wind up our discussion, and if we could get the roving microphone out. If we could get the roving microphone out, I'm going to choose a couple of facilitators just to read a couple of points. Just for the sake of time, and we only have about a minute or two, I just wanted you all to hear feedback on what you've been discussing. We are sending around a contact information sheet so that we can email you the results of these discussions at every table, so you have very good feedback on what you've contributed to us today. But just for a minute, I'd like to hear from a few facilitators, a few points, not in any depth. Remember, I'd like to give you about 15 seconds just to give a few points on what you've heard at your table. So any facilitator want to read a few points, 15 seconds, and our roving microphone will go to you. So how can we reduce the risk of our community members getting cancer?
So the chief and I sat here and we discussed quite a few things. One of the things that he's very strong on is the use of more traditional foods and medicines. The other thing, though, that we discussed was making sure that our people get to the doctor, just for regular checkups. In Alberta, we have a lot of residential school survivors who don't like to be touched because of some of the abuses they went through. So we need to make the programs culturally appropriate so that our folks can overcome those abuses so that they can address their own mental health, their own health and wellness.
Thank you. Another facilitator would like to read a few points.
So our table discussed returning to traditional diets a lot and using traditional medicines, but we also mentioned that we should increase the monitoring of carcinogens and contaminants in traditional foods, especially in light of major polluting incidents such as the Japanese nuclear radiation disaster. As well as sharing resources between neighboring communities and increasing the networking between those communities so that knowledge around traditional medicines and foods can be shared.
Thank you. Excellent ideas. And one more.
So we also talked a lot about the importance of traditional foods and getting back onto the land. We talked about mentorship as well, so as you're getting back onto the land and canning workshops, food skills workshops, sharing that and mentorship within the community so that that knowledge is shared amongst community members.
Thank you so much. And I'm very sorry we don't have time to hear from everyone. We have to move on. My apologies. Oh yes, I'm sorry. And as I said earlier, we will be sending you these results. If you sign in on your sign-in sheets and leave us your email, we will email you the complete results of our questions and notes from today. And again, my apologies for not being able to hear from you, but maybe at the next session, we'll try and hear from different tables with each question. So let's begin with the myth question number 2. Does treating, and you'll need your small voting devices for this. Does treating cancer with surgery cause the cancer to spread throughout the body? This is a yes or no or don't know question. A for yes, B for no, C don't know. Question again, and it's in the front. Does treating cancer with surgery cause the cancer to spread throughout the body? On the last vote, we got 67 votes. And let's see, we figure there are about 80 of you here, so let's see if we can get more of you voting this time. And you see the number of responses in the corner. Thus far, we've had 56 responses. A for yes, B for no, C for don't know. And Dr. Caron, I think this is completely out of my league. Maybe you should take this question. Let's keep the vote up.
Can we keep the vote up? They don't want to see me. Okay. So answer B. What was it? Yes, no? Let's see. What did most people say?
Oh, it doesn't say.
Okay. Most people said no. Can we revert back to the answers? So 63% said no, 18% said don't know, and 19% said yes. Believe it or not, I get asked this question A lot. And I think that it's an important question to answer because you always want to know what the pros and the cons or the risks and the benefits are of anything that you're going to be undertaking for medical care or your family member is going to be. The answer is B. It does not cause the cancer to spread throughout your body. Some of the reasons why patients, when I say that that's not something they need to worry about, some of the things they say is, well, I've heard that the cancer cells need oxygen, and so when you open up the skin, the oxygen gets in, and then the cancer cells get what they need, the food that they need, and they start to grow like crazy and they start to spread. So I can understand their reasoning because cancer cells do need oxygen because they're very rapidly reproducing cells. In fact, they're abnormal because of how fast they are growing and reproducing. That's what makes cancer so dangerous. The thing is that cancer gets its oxygen the same way that all cells in the body gets its oxygen through the blood supply. So you breathe in, you get the oxygen in your blood, the blood goes to the cells and they get it that way. So opening up the skin really doesn't have any effect at all on the cancer cells. I think part of the myth also comes from the fact that different types of biopsies, there used to be concerns about when the needle goes in to biopsy, say, a lump on your liver. The concern is that when the needle goes in, what if when you pull the needle out, the cancer cells sort of drop off the needle a bit, and then you spread the cancer cells those way in that small area? And I think that's a valid concern. And that's something that we consider as physicians before we can say, should we biopsy it, should we not biopsy it? Even in surgery, when I'm taking out a cancer, if I'm taking out a breast cancer or thyroid cancer or colon cancer, we're definitely worried about that in terms of spilling some cancer cells. And then we have colleagues like radiation oncologists and systemic therapy for chemotherapy that can help with cancer that spread, not only distance-wise, but the radiation can help with cancer that is invisible to the human eye but might still be there. Or, of course, radiation is there for cancer that can't be surgically removed. So the short answer is cancer or surgery does not increase the risk of cancer spreading throughout your body, or what we call metastasize. Surgery has a small risk of spreading cells in that general area, but it's very minimal. And all that information should be shared with you by your surgeon when you go to see them. And it's important that if this is a question you have, I've just talked about it briefly, make sure that you're with a surgeon that you feel comfortable asking those questions for and that your questions are respected. It does not cause the cancer to spread, and that's a reassuring thing, but always ask questions of your surgeon. If there's something to take away from this, make sure that you have that comfort level with any healthcare provider you're with. And again, how are we going to do that? Through the work and the input from you guys in terms of having a culturally competent system where our voices are heard and respected.
Thank you, Dr. Caron. All right, so discussion topic number 2. How can cancer services for community members from rural or remote communities be improved? How can cancer services for community members from rural or remote communities be improved? And you have 12 minutes. Thank you. So you have 5 minutes. 5 minutes left, and hopefully you've learned to be brief with your comments so as many of you can speak as possible. Thank you. All right, I'm so sorry to interrupt your very involved discussion. I'm sure you found lots to talk about, but we have only a limited amount of time today, and hopefully all of you are getting used to working this quickly on these very important questions. So if there are three volunteers, three facilitator volunteers who could take 15 seconds to read some points, hopefully the roving mic is nearby. At the very back, I see the first hand went up there. Great, and there are these two.
Okay. Hello, thanks
Great.
everyone. Yeah, so some of our comments that we really focused on was to try to build community capacity for community members to become healthcare professionals. Nurses, a lot of times community members stop at the licensed practical nurse, but have them become nurse practitioners and RNs as well as physicians, so that the rural areas have healthcare providers who will actually stay. The other key thing that came in all of our sessions, or all the questions, is that events have to be, or any kind of screening or education events have to be combined with community cultural events that are already happening, so that screening coming from the outside has to fit in with the cultural events that are already there, and that's where people will come. They said really bring the activities to where people are, and another focus was around men are reluctant to access screening and care, so using sporting events to do some education at, so go where the people are.
Thank you. And another facilitator volunteer, Melanie.
So there was discussion about having mobile screening that is not just for one type of cancer, so that there'd be screening for things like prostate, breast, skin cancer. And also some discussion around telehealth. So it can be an issue if phone lines are down or internet is down, but it could also be good in terms of having a community member meet the doctor over the telehealth before going down, or if their appointment's only going to be 5 minutes, that would save a lot of time rather than having to go all the way down to Vancouver.
Thank you. And our last facilitator volunteer.
Okay, so we spoke about the mobile screening, about how that would be very valuable for the rural and remote communities, and also the need for greater financial resources for medical transportation. And one of the things that was suggested was to use the old hospitals as a place to provide screening. So that's what they're doing in Ashcroft. To give adequate notice for appointments to reduce the no-shows. Let's see here. Better communication between the referring community and the cancer center. Train community members to be advocates. Provide greater resource materials. Support communities with prevention, like the smoking cessation programs that were going on.
Great, thank you. Some wonderful ideas. Really very, very helpful. All right, so let's get out your little voting devices. Question number 3 is, can stress cause cancer? Can stress cause cancer? A for yes, B for no, C for don't know. Can stress cause cancer? A, yes, B, no, C, don't know. And there's a question. Oh, let's talk later about the software because I have no idea. Dr. Caron and I were discussing the answer to this question.
Yeah, you should put D, I hope not.
Yeah, D, I hope not. That's good, that's funny. Which of you came up with that? That's. And we're just waiting for the answers to come up. Oh. And Dr. Caron, look, 68% said yes. 20% no, and 12% I don't know. So we were discussing, and we said there is no direct evidence that stress can make changes at a cellular level causing cancer. However, there is indirect evidence that stress-related behaviors can cause cancer. So stress coping behaviors like drinking, smoking, like food addiction and obesity can increase cancers. So, sorry, no direct evidence, but definitely stress-related behaviors contribute. So how are we coping with our lives, and what behaviors do we have that might be contributing to cancer? And that's related to resilience. Yep.
Yeah, Nick said it was a trick question. It's not a trick question. It's just one of the questions that as physicians we get asked all the time, and hence it's sort of the reason why it hit one of our top 3 questions to pose to you. The other thing is that what I see a lot when patients come into my office, and maybe I was supposed to see them 8 months ago and they've made their way in, is they have an incredibly stressful event that's happened in their life that has trumped everything. Or sometimes I see patients and then I say, are you up to date on your mammogram? And they say, it's just so stressful. I just got a new job, and my kids are teenagers now, or there's multiple different things that happen in life that are stressful. And one of the other things is, I think as a people that we're always used to looking after our family and our communities. And what we have to remember is that it's so important to look after ourselves even during stressful moments, stressful times, stressful years in our life. And so making sure that the stress coping mechanisms that Evan talked about, but also recognizing that even during stressful times, to find that spot to look after yourself for preventative measures and for screening measures so that we can stop the cancer journey there, so you don't have to go down the diagnosis and treatment journey that Nick put up there before. So an indirect link, but not at the cellular level, making the cells change into cancer when you're going through stress.
Thank you. And we hear from survivors that their mental health, not just their physical health, is important. So how they're feeling and how they're feeling about their diagnosis, and where they find themselves at the point of their diagnosis are important issues. So thank you very much. So a lot to consider in this question. The next discussion topic is what culturally specific resources or other supports can be provided to improve the cancer journey for our community members. So the question is about culturally specific resources, and you have 10 minutes. 8.5, maybe. I'm trying to shepherd you along so you can do your survey, and we have some graphics up here that we would like you to contribute to as well. This is your 1-minute warning. Your 1-minute warning. My apologies to discuss your, or to pull you back from your discussion early. Hopefully you've had time to respond sufficiently to this question. I do urge you to write an answer down if you haven't had time and leave it with your facilitator. I'm cutting your discussion short. My apologies. Please write your answers down on a piece of paper to leave with your facilitator. 2 facilitators, please, to discuss what has been put forward to them at their table. 2 facilitators. We'll go really quickly. Great. And the roving mic, I hope, is here. Where's the roving mic?
Or community is very individual and unique in what they do with their spirituality and customs and traditions. It's very diverse, so it needs to be looked into for each area. And does language help? And there was discussion about putting a video or DVD together to explain how the process would be, and to combine the medical terms with the layman's terms and utilize family members or friends that people can recognize and feel more safe and comfortable. Include traditional healers for community and have it be the individual client's choice.
Thanks
So,
very much. And one last facilitator, just to round off our discussion. Those are all great ideas.
We also had a lot of conversation about traditional medicine and how teas for patients can improve health, quality of life, and extend life. And also daily support from community health reps that are already in the community.
Thank you. And I'd also include cultural workers along with traditional healers that might be of some service. Thank you so much, all of you, for your responses to these 3 questions. That's been really very, very helpful to all of us who are working here. There are surveys that are on your table that we would like for you to complete before you go. So if you could, if you're having trouble with a survey, or if you don't have a survey, please put your hands up. We'll bring you one. And after you finish the survey, there are graphics up here that we would like for you to come and put stickers on. Oh, here they are. Here's an example, and there's several on the floor here, where you can put stickers for cancers that have affected your families. So, if you are from Vancouver Coastal, we ask you to put in a red sticker. If you're from Vancouver Island, a yellow sticker, an orange sticker if you're from the interior. If you're from Fraser, a blue sticker, and if you're from the north, a green sticker. And don't worry, we'll leave this up here. Just put a sticker of the appropriate color for your area and put it on a part of the body of a family member, or on the graphic of cancer that might have affected you or a family member. Thanks very much, and that will be before your break. One last item, please leave your clickers behind. Please leave your clickers behind. I can when you complete your survey, please hand them back to one of our volunteers, and they will give you a ticket for the draw for 2 mini iPads, which will occur tomorrow afternoon at the Beefy Cheeps finale. So when you finish your survey, just hand it back to one of our volunteers. They'll give you a ticket for a draw for tomorrow afternoon, Beefy Chiefs, where we will give away 2 iPads, mini iPads. All right, you are now officially on break. So if you could just take a few minutes to finish your survey and come and put a dot on our graphic, that would be great. For those of you who need to leave, you can drop your survey off at Salon B downstairs beside the trade fair. If you need to leave, you can drop off your survey downstairs beside the trade fair in Salon B, and you'll get your ticket when you hand it in. I'd like to thank you all once again, and thank you to our guests. I don't know if I should call you guests. We set this up together. Thanks. Oh yes, thanks to our partners, all of you here, all of the volunteers for this session. It's been very, very fruitful, full of fruit. And thank you again to all of you.
So the next session will be starting in about 15 minutes, and I think there will be some announcements in a minute, probably over the PA, but just so you know, you can sign up for an evening reception tonight at reception. There will be food provided, so go talk to the people at reception and check that out. Also, go down and check out the trade show. There's a whole bunch of really interesting artisans and different things happening on the second floor. And all of the PowerPoints for all of the presentations will be available in the forum final report, which will be posted on our website.
Test, test. Good morning. Just have a few announcements, a few reminders. Some people might call them commercial break. We're going to do some advertising, but just more reminders for you. We can hear cricket calls, so please visit the trade show. Complete your passport to win some fabulous door prizes. So those passports, remember, you can go to the trade show and get them filled out. Don't forget to sign up for our evening reception from 6 o'clock to 8 o'clock tonight. Dinner is provided. So there's 100 people to sign up. Did you also know that there was the breakout sessions that are happening on the 34th floor? The 34th floor is also your health screening. So please go up and see what's going on the 34th floor.
She has 38 years of healthcare experience, including 25 years in management and senior leadership levels in the fields of child, youth, and family health and public health. As Executive Director for the Population and Community Health Portfolio, Allison is responsible for Aboriginal health, rural health, and integrated primary and community care services. Allison has a Bachelor of Science in Nursing and a Master's of Science in Nursing Administration, and today she's going to be talking to us about developing an integrated care model in Oceanside, incorporating the learnings from the SouthCentral Foundation. Please welcome Allison Cutler.
Thank you, Erin. Thanks, everybody, for coming. And I'm just really appreciative of the opportunity to talk with you today. Are you able to hear me okay? Oh, good. Okay, give me the thumbs, the signal if you can't hear me. Thanks. I don't have the biggest voice going on here. So I am very excited to be here today and to have an opportunity to talk with you, I hope, and share some of our experiences in Island Health and the learnings we've had. I think for me, as you heard in my intro there, I've been in this business a long time, and I have to tell you that right now, in the last year or so, I'm probably having more fun than I've ever had. We're on a wonderful journey with incredible partners, and I think, and my team, I think, will agree that we think we're moving into a time of transformation rather than tweaking and reorganizing and just trying to make a bit more sense of the mess we sometimes find ourselves in. We're actually talking about transformation and doing things in a whole different way. I would really like to acknowledge that we are gathering on Coast Salish territory and thank the Coast Salish for welcoming us to their lands. I'd also like to introduce a couple of our team members that are here today. And partway through, we're going to do a little bit of a buzz. Hopefully there'll be more people in the room where it's going to be a very whispery buzz maybe, but I'll count on you to be excited. So with me today is Ian Knight. Ian, if you could just, probably many of you know Ian. Ian is our Director for Aboriginal Health at Island Health, formerly known as Vancouver Island Health Authority. We decided to dump the authority part and speak more to what our vision would be. And also with me today is Phil Lawrence. Phil's our Director of Integrated Primary and Community Care, so a real force behind the strategy that we're going to be talking about today. We're going to have time in the morning to share your wisdom and to have hopefully some conversations and buzz, but please feel free to ask questions as you go. So what do I need to do to make this baby go? There we go. So what we're going to talk about today is why we're making these changes in Island Health, what did we learn from SouthCentral, and how have we applied those learnings in Oceanside. So first off, I'd really like to know by a show of hands, who in the room feels they already know a lot about the SouthCentral Foundation? Good, right answer. And a little? Okay, so that's good. I'll carry on as I'd planned to and kind of talk through what I learned. I wouldn't assume to be able to tell the story in the same way that the people from SouthCentral can. And I know the First Nations Health Council, First Nations Health Authority have hosted trips and visits here. So I know some of you have had an opportunity to hear directly from them. And I would really encourage you, if you do get an opportunity, they have a conference every June, and they're very, very generous in sharing what they know. So for those of you in some of the other health authorities, you may want to take advantage of that. So why are we doing this? Why are we making these changes? It's a deceptively simple question, and the answer is incredibly complex, being that we're in this messy human world that we live in. Certainly, one of the reasons we're doing this is because we can't afford the healthcare system the way it's structured right now. You all have heard the stories, I'm sure, about healthcare costs escalating and the curve continuing, the gradient of the degree of spend as a proportion of the provincial budget getting steeper, and more of the provinces and federal government's dollars going to healthcare at the expense of other services and areas that are really important to influence the determinants of health. So healthcare services, best guess, 15 to 20% impact on actual health. So we do need, as a society, to think about what we value and where we make our expenditures. We also don't have the best outcomes. And those of you who work primarily with First Nations populations and in First Nations communities know that better than anyone about the disparities in health, and that despite our investments, we still have pretty staggering rates of complex chronic disease, mental illness, addictions, etc. So we're spending a lot of money, we're not getting to where we think we ought to with that degree of expenditure. Poor coordination of services, or maybe even very little no coordination of services some people would experience. So if any of you in the room have experienced a health challenge, a complex chronic illness, or help support a family member or friend through that, you know of which I speak, that you have to make that journey, often seemingly on your own, and you have to navigate between the different services. Often once you get into a service, it's fantastic, and you get what you need, but actually getting there is very difficult. Unless we get more patient focused and actually even move beyond that and get more community health and population health focused, we're going to continue to do the same thing. And you've all heard that adage from Einstein about the definition of insanity is continuing to do the same thing, expecting the same results. So is there a way out of this mess that we're in? Do we have an opportunity to actually create a system? I think, and many of my colleagues think, that the answer is yes. So at Island Health, we've recognized that there needs to be a better way, and certainly as has the First Nations Health Authority. We saw that yesterday in the celebration of cultures, and we heard that from the words that Joe Gallagher shared with the plenary yesterday afternoon. I think also the First Nations Health Authority vision of health through wellness is it just epitomizes that actually you're beginning to walk that walk now. So in Island Health, we committed as an organization to walk the talk of that there had to be a better way. And we saw that as one way to that path was to actually develop an integrated service model. And we started with integrated primary and community care, but we are now thinking that actually it's not just about primary and community care, it's actually about integrated care. So I'll use those words more today than just talking about integrated primary and community care. So we have restructured a little bit to give ourselves some space to actually focus on this work. We've created a team that Phil is leading to help form our strategy and to drive it forward. And we've developed some leadership tables where we are trying to engage the whole organization in this change, because it's not just a little team of integrated primary and community care. We need to impact the whole system to change the system. So our acute care partners, home and community care, mental health and substance use partners, they all need to be in this with us. And we have created tables where we can have those conversations, and we can talk about that a little bit more later. So we've created this new model for us, not new to society, and we base a lot of the principles of the model on what we learned from SouthCentral Foundation and their NUCA model of health. We really find that we're building a bridge while we're standing on it, that we keep our learnings grow and change as we move forward, and we're trying to be nimble and adapt to that. The model that I'm going to describe, or the expression of the model at Oceanside Health Center in Parksville, is we've only opened our final phase for the big phase one on September 30th. So we're in very early days of understanding what these changes mean, and so no doubt in another year there'll be a little bit of a different story to tell. I really appreciated what Joe had to say yesterday around, he described that you all were in the First Nations Health Authority building a road, trying to figure out what kind of road, whether it was a bridge or what that bridge would look like. And also, you also had to you're building the vehicle on which to travel that road. So finding all the parts and fitting them together and deciding, is it a sports car or is it a four-wheel drive truck or the dreaded minivan that you all need to have. So I thought that, I really understand that feeling. We've been experiencing it in Island Health. The slide magically changed by itself, so I'll just leave it up there. So in 2011, a team of 3 of us from Island Health, Ian and I, and my executive medical director co-lead, Dr. Bob Burns, had an opportunity to visit SouthCentral. We went on the trip organized by First Nations Health Council, and I can't say, I've said thank you many times, but I would repeat it here today because it was a game changer for all of us. And I hope you'll understand the enthusiasm that we left there with as I tell the story of what we learned and what we saw. So we learned about the organization, and it in and of itself is an amazing organization. And we also learned about their NUCA model of care, their primary care model. We wanted to know more, so we arranged follow-up phone calls, a follow-up video conference, and the team from the integrated primary care area of SouthCentral was so generous with their time and sharing their floor plans, their job descriptions. And then the following summer, we sent another team, so 13 of us from Island Health went, a group of staff, physicians, representatives from divisions of family practice went and had another opportunity to spread the learning that the 3 of us had, because I think some in the organization were getting a bit tired of hearing from Allison and Bob about we need to make some changes, and we have seen something amazing. So that turned out that Bob and I had got it right in terms of the impact, and the team of 13 that came away were as enthusiastic, and now we had a bigger core on which to start to spread the learnings. We were all just blown away with what they had accomplished, and over a period of time, so it wasn't a 2-week undertaking. At that time, their NUCA model of health had been in place for 13 years, and they shared with us they figured they're about halfway there. But they did challenge all the Health Authority and First Nations Health Council folks there to think about how we could spread further and faster and really build on the groundwork that they had created and some of the outcomes that they had experienced. So we went away and we wondered if we could do the same, if we could adopt some of the principles and the strategies within Island Health, being aware that we couldn't just plop a model from another organization in another community with different cultures, just import it as it is. But we thought there is so much strength in some of the underpinnings. We wanted to spread the learning about what they had accomplished and who they were, and also look at adapting it to fit our situation in Island Health and our diverse communities. You'll see on several of the slides, not this one, this is a photo that my colleague Bob took, but on many of the slides you'll see this SouthCentral Foundation logo, and they've generously agreed for us to use some of the slides they used in their presentation. So this is their primary care center in Anchorage. And SouthCentral Foundation is one of several healthcare foundations in Alaska. It's a Native Alaska organization, and they provide the health care for Native Alaskans in the Anchorage Bowl and down to the Aleutian Islands. So they have a full range of health care, and they also are the lead operator of the Alaska Native Medical Center, which is a hospital which is on the campus. And the earlier picture was of the campus. And the hospital is run in partnership with the other tribal organizations, And it was fascinating, I think, for the Health Council members in particular, to hear the story from the governors there about how they got there. So different views, different perspectives, feelings about Anchorage being the big guy on the team, and some of the smaller organizations feeling less power, under more control of the larger organization. But they got to a place where they're common in their goal, and they have their hard conversations in a room, and they walk out with one voice. So I think that was another good lesson for us. So the primary care model in Anchorage is referred to as NUCA, and it's a word that in the Alaska Native language means a strong structure and living things. It's a name that they've given to their whole health system. So the system is owned and operated by the customer owners, that's the people of Anchorage and the catchment area of the SouthCentral Foundation. And the intent is to achieve physical, mental, emotional, spiritual health. It's a model that is so successful that it's won coveted international and national awards. The most recent really big award was the Baldrige Award for Quality in Healthcare last year. And they have outcomes that are they're an exemplar for the rest of us. So with their population, they have reduced their visits to emergency by 50%. They've reduced their hospitalizations by 60%. They've shortened length of stay. They have got much better markers on some of the indicators of chronic disease. So if you look at how stable people are with complex chronic disease, they are leaders in all of those markers. They also have significantly reduced their staff turnover. So that's a good marker of staff wellness. And when you walk in the doors of any of their buildings, so primarily we spent time in the primary care center, you can talk to anybody and they understand their business and how they contribute. And you just get a buzz that I haven't experienced in any organizations I've worked in. Just very beautiful buildings, and the beautiful Alaska Native artwork throughout all the buildings are just stellar. So it is a genuine system of care. It's delivered by customer owners, that's the term they use, which we found just to be pretty powerful. The CEO, Catherine Gottlieb, would say they're owners because they prepaid for it with their history. But certainly they are very intentional about those words and about how they implement their care. It's whole person focused, and it's built on a foundation of long-term relationships. The transfer of control to the customer owner, and integration of mind, body, and spirit, and a commitment to measurement and quality. And I'll give you some examples of that a little bit later, but I just described some of their outcomes, but it was just amazing what they're able to produce, and their intention around measuring and talking about quality and doing the PDSA cycles, the Plan, Do, Study, Act cycles. So if you just stop and think about those words for a few minutes that underpin their model. So system, customer owner, whole person focus. The foundation is a long-term relationship and commitment to measurement and quality. And I know for me and my colleagues, we couldn't say that we saw all of that in our own systems, and we hadn't experienced that. So it was just so powerful. So this is Catherine Gottlieb. In 1987, she was a young Alutiiq Filipino, Alaska Native, and it was one of the cultural important things in Anchorage is that giving and telling of story. So every person that introduced themselves told their story, and it's a very blended culture because of the history of the world and how different cultures and moved in and out of Alaska. So she's very proud of her Alutiiq and Filipino heritage. So as a young woman, she joined the SouthCentral Foundation as a secretary. And at that point, SouthCentral in 1987 was a healthcare corporation before the transformation in their healthcare system there that provided limited dental and behavioral sciences to local Alaska Natives. Today, 28 years later, she's a grandmother, as well as is the CEO of this large corporation, and which now provides broad healthcare services, so prevention through to acute tertiary palliative care, the whole system, to about 60,000 Alaska Natives living in the Anchorage Bowl. And the term Alaska Natives is the preferred term that the people of the Alaskan Natives like to be referred to. So that's why I'm using those words again intentionally. So her name is Catherine Gottlieb, and she really personifies SouthCentral. She's an amazing person. And I think the story of how they started when the transformation occurred was that they listened. They stopped and they listened and they heard, and then they changed. So they were, one of the words that we really pulled away from their culture and their story of their organization is the word intention and being intentional. And we have found in our work that is so powerful. So very intentional listening over a period of months to what their constituents had to say before they moved and changed. And I think I heard Joe saying that yesterday too, around how important listening is. So they're very clear as an organization about what business they're in and what they want to achieve. And as I said earlier, you can walk into you can speak to any staff member, just the person at the reception desk, a nurse somewhere in the Alaska Native Medical Center, and they can tell you very clearly and enthusiastically and articulately what their vision is, what their mission is, what their core concepts are, their operating principles, and how they contribute. So again, not an experience that I had had, or Bob had had, or Ian had had in any of the organizations in which we had worked. And certainly I know in our health authority, we use the Gallup poll to assess staff engagement, and boy, we've got a long way to go. Staff don't understand how they contribute, and they don't know the big picture in many, many situations. SouthCentral Foundation is genius with acronyms. So these are their key points that, again, any staff member can tell you without pausing. Shared responsibility, commitment to quality, family wellness, SCF, SouthCentral Foundation. Their operating principles. Again, you saw this yesterday with the evolution of the First Nations Health Authority, and you have adopted the concept of operating principles and chosen the word wellness as the acronym for you. I think a couple of the principles to highlight from SouthCentral Foundation was that of relationship between the customer owner, the family, and the provider. So that's the core, is relationships and long-term relationship. Emphasis is on wellness and the whole person and their family and community. Intention, being intentional. Again, we heard that over and over again and saw that in their actions. Interests of the customer owner drive the system. This is sounding a little bit different than probably our lived experience in our some of our health systems here. And populations based, and services and programs built on the culture of the communities. This is the foundation, and this is something that we have adopted in Island Health. That primary health care is the cornerstone for families, for clients and their families over time, emphasis on the long-term relationship aimed at advancing the client's goals of health. So, primary care is a cornerstone, long-term relationship, include families as well as clients or the people we serve, and the focus is advancing the client's goals of health. So the reason that SouthCentral got to thinking about why this was so important and how this could transform the system and create some different outcomes for their people was really getting clear on who is in control, who really makes the decisions. So if you have a motor vehicle accident, a car accident, you fall off your bike and you're badly injured and you're taken by ambulance to an emergency unit near you, you have very little control. You just need to trust that the people that are looking after you know what they need to do and know how to do it safely with a high quality. They're going to put those bones back together. They're going to stitch you up. They're going to do all the investigations that need to happen to make sure that they have patched the parts of your body, not your mind, spirit, and soul, but your body that are broken in that instance. But in day-to-day life, and when you have a chronic disease, mild, moderate, or complex, or you suffer from mental illness at whatever degree, or have an addictions issue, you're just living your life, actually the health system has very little control. And you may have experienced having a conversation with a healthcare provider, probably a physician, who gave you advice that went like, you should, I'm going to write you a prescription for, I need you to change this, and you walk out of the office and the provider has no control over whether you filled the prescription the way it was written at all. If you did, do you take it the way it was prescribed? Do you even understand the story you were told about how you should take it? Do you decide to share the prescription with a family member, or not even fill the prescription, but you think your neighbor had something like that, so you just borrow their leftover pills? So in reality, it's the family, it's your social network, it may be the media, it may be what you heard from Dr. Phil has way more importance than what your care provider told you. So the final decision that influences your outcomes is with the person. In the NUCA model, the customer owner. The influences are family, friends, and coworkers, religion, values, much more than the system. This gives us some real opportunities to influence behavior, because it's the behavior of the person on their journey to health that makes the difference. How you decide, and we heard again yesterday, the challenges of the beefy chiefs, and again, individuals within the communities making choices about their own behaviors that would impact their health. And our current model is really one of tests, diagnoses, treatments without attending to the whole person and what it takes to actually make the changes. Again, I just love this slide from SouthCentral, which again they've so graciously shared. So it's about when you want to hit a target, when you want to reach a goal, get to an outcome, can you use a rock or is it really a bird? And in an industrial mechanistics endeavor, like medicine can be, you can, if you practice hard enough, you can throw the rock and hit the target. If you practice, you're going to get it right. But in a complex, messy human system, you're actually just throwing the bird. So it's not about hitting a target, it's what are the attractors? How can we make it so irresistible for the individual to get to where we think we want to go? So what is it going to take? What are all those influences that need to happen? And it really is thinking about our healthcare system as a service industry, not an industrial industry. And we sure don't in our current model. We leave it to the service recipient to find their way, and we talk about our own piece of it, and we give advice often, and I'm generalizing, but overall, the takeaway from most people's experience with the healthcare system is not one where they feel in control and can influence, but that they are recipients of a service that they may have a little bit of say in, but at the end of the day, they actually control their behaviors. So this is a summary of the NUCA system. It's about relationship, it's customer driven, They pride themselves on same-day access, so in their primary care center, if you call before 3 o'clock and be there by the time they close, they'll see you. None of this 3-week wait. They use a technique called max packing, and that is that they do everything that they can do for you in that day. So there is no sign that says only one problem today, please, or make 2 appointments if you have 2 problems that you might have seen in your own primary care physician's office. Staff work at the top of their license. They have service agreements with other parts of the system, which is brilliant. So they have service agreements between primary care and some of the specialty surgical services, that the primary care team will work up the patient to a certain degree so that they would never refer someone who had abdominal pain not yet diagnosed. Because sometimes that turns out to be constipation, and that's not a good use of the surgeon's time. So they have these commitments back and forth about the level of assessment that the primary care team will do, and then the specialty service, so example of a surgeon, has made a commitment about how fast they'll see the person, and if they do need a surgical intervention, how fast that will happen. So it's not that more passive, I'm going to make a referral, wait to hear from the surgeon, then they'll see you, then you'll go on another wait list. They have totally changed their approach in that. Really big on job progression, career ladders, mentoring. So the story of Catherine Gottlieb, who's now CEO, coming in the door as a secretary, currently the CEO, has been supported in her career laddering and her education. She's very highly educated. They don't hire based on, I've got a vacancy, I need to find someone. As people walk through the door, if they see that they fit with their organization, they just bring them on. And it's about fit, and actually, do you really want to live in Alaska? Have you been here in the winter? I know it's pretty when you came on your cruise, but, and then they fit them into the roles that they have available. A lot about giving and receiving story. They're very accountable. And they put services into their culture rather than culture into their services. Subtle change of words, very important. Asset-based, and they really focus on their operational principles. So that's the story of SouthCentral and what we learned. And again, I don't want to presume to be able to tell the story of SouthCentral the way that they could. But I've shared with you my learnings, and what we'd like to do now, and you might want to join up some tables because we've got some pretty sparsely seating here, is just have a little buzz, and let's take 5-10 minutes, we'll see where the conversation goes, and talk about how you see that we could apply these learnings within the communities that you're working in BC. Sound okay? You want to move a little bit? Our team's going to wander around a bit and gather some of the conversations. Then we'll just have a quick feedback. I'm not asking you to write it down and do flip charts. Let's just have a bit of a conversation.